Good evening, everyone, and welcome to the Recently Diagnosed Everything You Should Know webinar. My name is Rebecca Gillet, and I am an arthritis patient like you, living with rheumatoid arthritis and osteoarthritis. I'm also an occupational therapist and have been a longtime volunteer with the Arthritis Foundation, currently on staff as the Director of Content Strategy and Planning. And I'm also the host of our podcast, Live Yes with Arthritis. Thanks for joining me tonight. I know that firsthand, when I was first diagnosed with arthritis, I had so many questions like you might have. You may feel very overwhelmed, and that's why tonight's experts and I will share key information to help you manage your symptoms and disease, including treatments, lifestyle measures, and daily living tips so you can live a full life with arthritis. One resource that can help you live your best life with arthritis is our new VIM app at the Arthritis Foundation. Through the app, you can track your pain and symptoms, set realistic goals for better arthritis management, and cheer on a community of other people living with arthritis like you. Let's get started by introducing our wonderful expert panel joining me this evening. First, we have Dr. Mahsa Tehrani. She is co-founder of the Arthritis and Rheumatology Clinical Center of Northern Virginia. She is double board certified in internal medicine and rheumatology and currently serves as an expert reviewer for the International Journal of Rheumatic Diseases. She is also the contributing rheumatology expert to their Health Answers column and a member of the American College of Rheumatology, DC Rheumatism Society, and the American Medical Association. Next up, we have Dr. Carla Harwell. She teaches both medical students and residents at University Hospitals Cleveland Medical Center, where she also serves as an associate program director for the Internal Medicine Residency Program. She also serves as a clinic preceptor and director of the Douglas Moore Residence Clinic at University Hospital Cleveland Medical Center. Dr. Harwell serves on many local, regional, and national boards and has received numerous awards and honors, including ranking nationally as a top doc by U.S. News and World Report for the last 11 years. Next, we have Dr. Donald Miller. Dr. Miller has more than 45 years of experience in pharmacology. His expertise in rheumatologic medications, including biosimilars. He is a professor in the Department of Pharmacy Practice at North Dakota State University and has published several articles in various medical journals. Dr. Miller is a longtime contributor and reviewer for the Arthritis Foundation's content, so you'll see his name on our website a bunch, including its annual drug guide. He is also a recipient of Al Door's Service Award for Outstanding Public and Professional Service to Pharmacy. And last, but certainly not least, we have Dr. Elisa Curry. She's a board-certified geriatric clinical specialist through the American Physical Therapy Association, where she is also the chair of the Total Joint Replacement Special Interest Group. As chair, she oversees a network of rehab clinicians treating patients with total joint replacement. She is also currently the coordinator of rehab clinical programs at Washington Hospital Healthcare System in Fremont, California, which also includes rehab oversight of the Institute of Joint Restoration and Research. Dr. Curry works directly with adult patients with arthritis at all stages of treatment. Thank you all so much for joining me tonight. To kick us off, I'm going to hand it over to Dr. Tehrani for a brief presentation about arthritis disease basics. Dr. Tehrani.
Thank you, Rebecca. Great to be with all of you. Thank you. Very excited to join you guys and talk a little bit about arthritis this evening. So I was asked to discuss a little bit about the basics of arthritis. We hear the term a little basics, arthritis 101. What is the joint? What is arthritis? Well, arthritis is inflammation of the joint, which is where the area where the two bones meet. The cartilage in the joint is what allows the joint to function, to move, to bend and extend. It absorbs the shock when all of us are walking or moving. The unfortunate thing about cartilage is it does not grow back when it gets damaged or as it gets worn away with time. How do we advance to the next? Okay, great. So there are a lot of different actually types of arthritis. In my clinical practice, I like to educate my patients about what we're evaluating for. I think it's best to think of arthritis kind of as this kind of big tree with two really large branches. The first branch is your degenerative and or osteoarthritis and or the wear and tear mechanical type of arthritis that happens usually with aging and over time. The other really large category is the inflammatory arthritis conditions, which can be where the immune system starts to attack the joints. This is your rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, those kinds of immune system mediated arthritis conditions. There's another kind of subset of inflammatory arthritis, which is gout, which is not necessarily immune system mediated, more of a crystalline buildup. Various crystals can contribute to an inflammatory appearing arthritis. And we have fibromyalgia listed on this slide. Fibromyalgia is not necessarily an inflammation of the joint. It is not an arthritis. It's really a condition where there is generalized systemic pain all throughout, not necessarily confined to the joints, rather to the muscles and soft tissues. We do see this kind of overlap with the other 2 or 3 arthritis conditions at the top. A few features where we distinguish one from the other type, those 2 big branches, your mechanical osteoarthritis versus the inflammatory arthritis conditions. First of all, osteoarthritis is typically limited to the joints. Patients come in, the knee is painful. The thumb joint is very painful when they're writing. Whereas in the inflammatory conditions, the entire body really can be affected. Not only can the joints be affected, but you can get skin rashes, you can get internal organ involvement. My big concern with rheumatoid arthritis, for example, or lupus arthritis. And these diseases can also affect lung function, kidney function. So we have to be very vigilant. And these conditions, the inflammatory ones, can cause a lot of fatigue. Patients complain of feeling tired a lot and intermittently can also experience fevers. Osteoarthritis can affect obviously more than one joint, but not necessarily symmetrical, whereas a lot of the systemic inflammatory conditions can be symmetrical. There are exceptions to the rule, and our bodies do not follow the rule, but these are some general guidelines. The osteoarthritis tends to occur gradually over time. The inflammatory arthritis conditions can happen gradually, or really somebody can wake up and within a couple of days have this massive, sudden, symmetric pain. The osteo happens usually in the overused joints, for example. The knees are very common. And the inflammatory conditions can happen to any joint, even without overusing it. One big distinguishing factor, we have a lot of patients who have multiple types of arthritis. One big thing is, do the joints hurt more at the beginning of the day or at towards the end of the day with overuse? What we see with osteoarthritis is the joints hurt more when you're overusing them, whereas in the inflammatory conditions, patients wake up with a lot of pain and stiffness and actually tend to get a little bit better as the day goes on. So that kind of captures the gist of this slide. And then breaking down the other types of arthritis, the crystalline or conditions, gout being a big one. We also deal with pseudo-gout. Both are caused by crystals becoming deposited in the joint. Gout we see more frequently in our men patients. Typically, the big toe becomes affected, although lots of other joints can be affected. Usually the attack a lot of times can start to occur during the nighttime. Flares can last a few days. They happen suddenly and there is severe, intense pain. What the textbook is when the patients are complaining that the sheet is even hurting their toe or the joint that's affected. Over time, if this is becomes a chronic condition, you can get calcifications called tophi that we can feel and palpate. And unfortunately, a lot of times symptoms are exacerbated by consumption of red meat, beer, shellfish, for gout patients. Fibromyalgia, again, is not necessarily an arthritis condition. This is more common in women. Patients complain of a lot of tenderness all throughout their bodies. There are trigger sensitive points, widespread diffuse pain. A lot of times we hear complaints of brain fog, lots of difficulty with concentrating, focusing, fatigue, sleep issues, and sometimes low mood and anxious mood can be associated with this condition. This slide is talking about the importance of symptom tracking. Whenever I see my patients, I ask, are you better? What part of the day do you get better? When are the symptoms worse? When you track or keep a mental, or better yet, actual physical diary of your symptoms, let's say for 2 weeks, that can help us understand the patterns a little bit better and devise better therapeutic regimens for our patients. So it's really important to track symptoms, and now you can also do it electronically. And specifically, which symptoms to track? Okay, so what is the nature of the pain? Is the pain dull ache? Is it sharp shooting pains? These can all give us more information about what we're treating. Is there associated stiffness? Is it worse in the morning or worse at the end of the day? Is your flexibility being affected? Do you see any warmth and redness and swelling, or is it just this dull ache? Do your joints give out, or you feel like you're falling? Again, these can all help pinpoint the underlying cause of the pain a little bit better. So a lot of patients come in and they say, oh, so there's no cure for arthritis. Well, there unfortunately not yet. There is not a cure yet. But when you meet with your physician and you have a great group of personnel basically there for you, and you come up with a comprehensive treatment plan, then a lot of times the pain is not debilitating, and we can get it really under really, really good control. So, when I say comprehensive treatment plan, that includes not only pharmacologic therapies, but there is a lot about non-pharmacologic therapies and self-management modalities, which can help reduce this pain, improve mobility and function, and overall, the goal is improvement of your quality of life. The three-legged stool, or the three-pronged approach. So this is essentially what you want to have in your toolbox, and you want to make sure you have some from each leg of this stool in order to have the most holistic therapy for your arthritis. What does that mean? What are these prongs? Like I mentioned earlier, medications, pharmacologic therapies, that's why they are there. We have to use them, but we have to use them judiciously, and we'll talk about that a little bit later. Lifestyle measures, huge component, equally as important as the other prongs in this. Your diet, your physical activity, your body mass index, all of these can be very, very significant aids in the management of arthritis symptoms. And absolutely the mental, the mind-body connection, stress management and emotional wellness can be of paramount importance. When somebody's feeling down and not feeling good, they may neglect their lifestyle measures. They may neglect that diet they created for themselves. So for that reason, all these three legs are extremely and fairly equally important. When we talk about medications, there are a lot of options. The first step is, as a rheumatologist, I have to identify what type of condition I'm treating. If it's osteoarthritis, then a lot of these medications on the screen, like the disease modifiers and biologics, don't do anything. So once the diagnosis is rendered, then we have a whole arsenal of therapies that we use in various orders. Really, the treatments have to be custom tailored to each individual patient. Your underlying medical history, somebody has cardiac disease, somebody has kidney issues, somebody has liver disease, then a lot of these pharmacologic therapies are off the table. So that's why it's so important for you to make sure your rheumatologist is aware of every single underlying condition, medications you're taking, so that they can use the best medications for your symptoms. And as I mentioned, talked about earlier, it's your arthritis healthcare team. It is exactly that. It is not just the rheumatologist equally important. Your primary care physician, I always say they are the air traffic controllers. We send them all these notes, all these specialists send their recommendations. Well, they're responsible to take this and talk to you about it. So they're very important. Your orthopedic team is very important. Pharmacists, absolutely, but we're in touch all the time, asking about this drug, interactions, physical therapy. I think I can't think of one patient that I can't recommend physical therapy and occupational therapy to. Extremely important. And of course, nurse practitioners, physician's assistants, mid-level providers, it's a team effort. Movement, we tell everyone about movement. So this falls under that prong of the self-management. Of course, it helps hydrate the cartilage, it decreases inflammation, weight loss, or having an ideal body mass index is absolutely paramount, especially in some osteoarthritis conditions. But now we're learning more that the body fat can increase inflammation. So our rheumatoid patients, psoriatic arthritis patients are at increased risk of cardiovascular disease, heart attacks, strokes. You want to really get your body mass index to the ideal range for optimal benefits. Routines can include aerobics, cardio, strength. I love strength resistance for a lot of different reasons. Muscle building helps support the joints, hence another reason I refer to physical therapy. But in a lot of our patients who may need corticosteroids, rheumatoid patients, we're going to be increasing the risk of osteoporosis. So strength training becomes important in helping maintain your bone density. And self-management, beautiful slide here, so colorful. You got to eat the rainbow. That's illustrated really well here. Key benefit, we know good eating, healthful eating will reduce systemic inflammation. We know that there are studies that show C-reactive protein is an inflammatory cytokine, and this number comes down with lowering your body weight, with eating a healthful diet, with turmeric. We can talk about all that stuff more later. And of course, healthy choosing habits. There are a lot of different diets out there. A lot of times I found that when my patients seek a nutritional counselor to talk about an anti-inflammatory or more of an autoimmune diet, they do really well because they get really direct directives about what to follow for breakfast, lunch, and dinner. Fruits and vegetables, lean proteins, healthy fats, extremely important. Big things to avoid for all of my rheumatologic conditions. Minimizing sugar. Sugar is an evil. High sodium diets, high fats, processed foods are awful. And hydration is extremely important. Kind of talked about this a little bit with the physical therapy and non-pharmacologic therapies. All of these things can be helpful. Massage, Reiki, acupuncture, there are studies that it can help back pain, knee pain. So I use all of these in my management of my arthritis patients. The emotional health that we talked about a little bit earlier. Again, if you're feeling down and tired and you just don't want to get off the couch, you're not going to do your workout. You're not going to go prepare that healthy food, or you'll go to the drive-through and pick up some McDonald's. So it is all interrelated. This is really all a domino effect. You got to take care of your emotional health. There's some modalities listed here. I am a big fan of recommending Tai Chi to my patients. There's scientific data about Tai Chi and fibromyalgia pain relief, about knee osteoarthritis pain relief. All of these modalities listed here can help. It's a lot of trial and error to see what works best for you. This slide is also very important. Absolutely, if your disease is not really holistically 360 degrees treated, from the perspective of the three prongs that we talked about, other health issues can arise. Absolutely, mental health can suffer. I talked about the steroids and not moving around too much, low bone density, leading to osteoporosis and bone fractures down the road, and the association of cardiovascular disease, diabetes. These diseases, rheumatologic conditions, are very all-encompassing. They are really head to toe. We cannot just focus on one thing and call it a day. It's all interrelated. Absolutely agree about consistency. I think it's very important for all of us to realize we are all human. We cannot be, running marathons and eating a healthy diet every single day of the year. There are holidays, there are celebrations, there are weddings, there are a lot of different things. You got to kind of factor that in, and you got to be forgiving and understanding. You just got to say that, you have to try to understand if you have a not so good day, not to just give up. So consistency is key, and that's essentially what this slide is talking about.
Thanks so much, Dr. Tehrani, for such a well-rounded look at arthritis and explaining some of the basics. Now we will begin our discussion about the top things that you need to know about managing a new arthritis diagnosis. As a reminder, you can type in any questions you may have in the Q&A chat function at the bottom of your screen. Please keep in mind, we received hundreds of questions before the webinar, so we'll try to get through as many as possible today and answer some as they come up. But please be patient and feel free to reach out to the Arthritis Foundation helpline for answers to your questions if you're unable to get to yours today, if we are unable to get yours today. And also just take a look on our website as well. You might find some of the answers you're looking for. So to kick off this discussion, I'd first like to pose this question to our panel. When I was diagnosed, I was 26 and I didn't know anything about arthritis, really. I knew of it. I think I was like many of the general population who think it's a singular disease. So I want to know from each of you, what do you think is the first thing a newly diagnosed person with arthritis should do to set themselves up for success? And I'm going to start with Dr. Harwell, if you can get us started, and then I'll move on and have each of you answer. Dr. Harwell?
Sure, and thank you for having me as part of this great panel discussion here. So I would say the first thing is to know that you need to be an active participant in your healthcare, because no one is going to take better care of you than you. Be educated about your disease and this diagnosis, such as this seminar that we're doing this evening. Learn, what does it mean to have arthritis? What is that? Gather all the information that you can so that you're educated and that you can be an active participant in your healthcare. And most importantly, don't do this alone. Find support. Find support from your family, your friends, support groups, and even your healthcare professionals. But you're not alone in this journey. So become educated, be an active participant, and find support. Don't do this alone.
Thank you. That's a really good answer. Dr. Curry, would you like to answer the question as well? What's the first thing a newly diagnosed person with arthritis should do to set themselves up for success?
I would definitely echo everything Dr. Harwell just said. That was fantastic. And again, thanks for having me as well. I would say that one of my favorite sayings is, you can have things good, you can have them fast, or you can have them cheap. Pick two. Okay. And with that, that means that you really do have to invest in your own healthcare. Education is a healthcare strategy, and healthcare is a team sport. So there is a team of people that are good at their particular discipline, and you have to utilize each member of that team. And the patient is a team member. It's an active team member to the process. So we need to learn about the patient and what realistic activities, what realistic lifestyle they want to live. And then we develop a plan that the patient then undertakes. And that plan is going to take a lot of different iterations. But the key thing is the constant tweaking of the process. It's never a straight line. So just remember that there's going to be a lot of ebbs and flows, a lot of peaks and valleys, and a lot of twists and turns, but there is never 100% stop. There's always things to do to make your life better, make your life a little more manageable, and not to give into this process.
I love that answer. And the team analogy that you gave, I love it. And as an OT, I would say 100% agree with everything you just said. And also say that you don't have to stop. Occupational therapy can help you adapt, right?
That is
And
correct.
so that's another good person to have on your team. Dr. Tehrani, can you go ahead and answer and weigh in on your thoughts, what someone can do to set themselves up for success in managing their arthritis if it's a new diagnosis?
Absolutely, like Dr. Harwell and Curry, and I agree with everything that was just said. Kind of building on that, you had mentioned education and support. I think the education about what is this disease, what are the diagnostic criteria, really, I just really getting deep into their condition to understand. I have a lot of patients that come in. Let's say you have rheumatoid arthritis, they come in with back pain and they think it's the rheumatoid flaring. This gets them unnecessary anxiety about step changing their biologics, whereas not every single little thing is related to that disease. That's why it's so important to understand the disease. What exactly is it? So I think spending time, like Dr. Harwell said, and understanding it and the features of it can quell some of the anxiety when there are potential issues or complications or new symptoms that arise.
Yeah, thank you for that answer. And then Dr. Miller, and last but not least, what would you say from your perspective as a doctor of pharmacy, because that's a huge part of managing arthritis for a lot of people, especially with inflammatory types of arthritis?
Yes, again, thanks for having me on the panel. I would definitely recommend, if you don't already have a favorite pharmacy and favorite pharmacist, get to find them because you'll probably be taking a lot of medications, may be interested in supplements. So find a pharmacist that you really trust and who you can speak to about your issues. Maybe also tempting to get cheaper medicines through mail order, but if you have a personal relationship with your pharmacist who knows all the medicines and supplements that you're taking, they'll be able to give you much better advice.
I love it. And if I can say so, I think everybody that you all represent on our panel here, that's your dream team. If you just got diagnosed with arthritis, you need a rheumatologist, you need a physical therapist, you need an internal medicine or primary care physician, and a pharmacist and an occupational therapist on your team. And if you start out with that, you have the right people on your team to help you navigate this journey. So let's move on to the topic of questions of medication use and types. So the first topic we will talk about is getting started with the medication and treatment regimen for arthritis that's right for you. And remember the different types of arthritis that Dr. Tehrani mentioned, there's different treatments for each. So we'll start with you, Dr. Tehrani, and I'll start by asking this question of how do doctors decide which medications to try first? Are there certain medications better than others when it comes to treating inflammatory arthritis versus osteoarthritis?
Yes, absolutely. The management of osteoarthritis and inflammatory arthritis can have some common treatments, but they can be day and night different. So those are again different categories. As to which drugs, we try to minimize pharmacologic therapies. We know they are a foreign chemical substance. We know they can have side effects. And my goal as a clinician is to use the least amount of medication, but achieving our goal. You don't want to have this, unchecked disease activity, which can contribute to joint damage, irreversible damage, organ damage. But at the same time, we have to be cognizant of side effects. So how do we start? We start with a lot of times, again, there are a lot of nuances to this, but a lot of times, with these toxic medications, with the less potent medications, do we achieve our target? If yes, beautiful. If not, let's add it more. There's some controversy about this. Some of the inflammatory arthritis conditions, now they're like, let's knock it out really quickly first and then step it down. We can do there are different strategies, but always less med is what we strive for.
Can you
And I have to say, sorry, I have to interrupt that too. Other than the basics and the generic medications that have been around for decades and decades, when we get into the higher level, the biologics, a lot of that is not dictated by us. It's more dictated by insurance companies. So there are multiple levels and barriers that we have to overcome. And then the patients, do they even have insurance? There's a lot of logistical issues, unfortunately, that have to kind of shape how we proceed with therapies.
Oh yeah, definitely. Have to check to see what your insurance coverage is if you have it. So yeah, definitely an important issue to bring up. A lot of people are probably hearing from their doctors about a treat to target strategy. Can you explain what that means and how that's used in the context of treatment for arthritis?
Sure, treat to target can be employed in a lot of different disease conditions. Rheumatology in particular, let's say rheumatoid arthritis, the goal is remission. I tell my patients, I see 80, 90-year-old patients who come in with wheelchairs. My 18-year-old who comes in, 19-year-old who's diagnosed is crying because they think that's going to be their outcome. And I say, no, that should not be anyone's outcome if they're young and diagnosed without any joint damage. We have amazing medications now. So treat to target is the goal. The goal is to get them to remission, is to not feel like they have the disease. And so that's the target. We establish that by doing joint counts, there are disease activity measures, rapid score, DAS-20. There are a lot of different measures we can use to get the patients to a really low score, so low or remission. That's what that means.
Great, thanks for that explanation. And then one other thing, Dr. Tehrani, before I switch, what about medications, using medications that are off-label? What does that mean? And should I be concerned when an off-label medication is prescribed?
It depends. In rheumatology, actually, a lot of our drugs, specifically, for example, for lupus, have actually been off-label. A lot of these drugs we use don't actually have, for example, a lupus indication, but we know these drugs are staples and we use them. So, if I'm using something like methotrexate for lupus, fine, but if I'm using some anti-parasite drug that's given to, in veterinary medicine, I would absolutely not do it. In general, yes, we should be cautious of using off-label therapies. Why? Because the FDA has not approved them to treat the condition that we're trying to treat. But if it's an off-label that's widely acceptable, that's a different story.
Yeah, always talk to your doctor and your pharmacist,
Always.
right?
Always.
So Dr. Harwell, how can a person's primary care doctor and rheumatologist work together to comprehensively manage a patient's arthritis care? I know that is a struggle, especially when they don't have medical systems that speak to each other and doctors are busy. How do you know they're communicating? What advice can you give?
Well, it is a challenge, but I mean, the biggest thing is you want to listen. You want to listen to the patient and you want to collaborate as best you can. The left hand needs to know what the right hand is doing. And like you said, sometimes that's difficult when, you're in two different hospital systems that don't speak to each other. And what I mean by that is, electronically with medical records. But for sure, if it's within the same hospital system and you're privy to the notes, the clinic notes, when they see the rheumatologist, I always make sure when I go in to see my patient that I look at every other note that they, any other specialist that they've seen since the last time I've seen them, and I review those notes. So most of the time I walk in and I'm able to tell the patient, what's been going on with them before they even have a chance to tell me what's been going on with them. And that makes them feel good because it makes them feel that, I'm vested in not just making sure they get a mammogram or a colonoscopy or whatever. I'm vested in their total care. And so I think from a healthcare professional standpoint, it's all about collaboration, whatever that means. When I have patients that are in different hospital systems and I'm not privy to those notes electronically, I asked those patients, I said, bring anything from that visit with you. Most of the time now with the electronic medical records, there's a clinical summary that's printed out that patients are sent with, and, patients might forget to bring it, and so I just have to go with, the best that they can tell me. But I think the patients feel comfortable and feel safe knowing that their primary care physician is trying to at least collaborate with with the rheumatologist and know what's going on. It can get tricky sometime, like I said, if the left hand doesn't know what the right hand is doing. But for the most part, I think that, and I hope that most of my colleagues as primary care physicians are looking at what the rheumatologists are doing and, just making sure that we're staying abreast to the treatment plan and what's going on.
Yeah, for sure. And I just want to remind everybody that the common factor between your primary care doc and your rheumatologist is you. So don't be afraid to speak up. You have a lot of questions that you want answered, ask them, write them down so you don't forget. And you own your body and you are the expert of your body. So speak up and use your voice. That's the only way you're going to make sure that communication is going both ways, right? Is you making sure that you bring up those questions. We'll continue on talking about medications, but specifically side effects. So Dr. Miller, you're up. Many people are concerned about medications side effects, especially over the long term. What are the most worrisome side effects and just how common are they? And are there ways that we can prevent them? I know that was a lot of questions, but you can start with whichever one you want there.
Yeah, that's a huge question because there's so many medicines that patients take.
Right.
But I'll start with a non-steroidal anti-inflammatory drug, since virtually everyone who has arthritis is going to be taking one of these. Non-steroidals mean ibuprofen, naproxen, Voltaren, things like that. So probably we're all aware of the fact that it can cause stomach problems, sometimes just nausea, but they can also cause gastrointestinal bleeding, which could be pretty serious. So taking these medicines with food will reduce some of the nausea, but not necessarily the risk of GI bleeding. So if you're at high risk of gastrointestinal bleeding, you can take a medicine with it, like a proton pump inhibitor, that will reduce that risk. Non-steroidal anti-inflammatory drugs also can cause fluid retention and increase your blood pressure, even carry some heart risks. So make sure that you talk about those issues with your physician. Other medications, methotrexate is very commonly used in rheumatoid arthritis, and that can cause nausea quite commonly. There are ways to work around that as well. We can take methotrexate by injection instead of by mouth, if that helps. You can split up your weekly dose of methotrexate into 2 or 3 doses if that reduces nausea. And we can use a folic acid supplement also to reduce nausea and other side effects of methotrexate. It's important to realize that you may look at a long list of side effects with your medicine, but not every patient is going to get all those side effects. In fact, you may not have any side effects at all from your medicine. Hopefully that'll be the case. So again, work with your pharmacist and your care team to find ways to find the best medicine and make adjustments as needed.
I think one of the things I think about too is, especially if you have osteoarthritis or, those of us that have had an inflammatory type of arthritis and you rely on NSAIDs, is that you really need to pay attention about how many you're taking a day. And because that eventually could affect your stomach, right? And so
Yeah.
talking to your doctor, your pharmacist, there are other NSAIDs. Yeah,
we want to minimize medicine. So
right.
There are times when you have to take maybe a high dose of a non-steroidal temporarily if you have a gouty arthritis flare or a real bad flare of your rheumatoid arthritis. But our goal is to use the lowest dose for the shortest possible time. In our way, we want to switch you over to disease-modifying drugs so you don't need non-steroidals anymore.
Right. Thanks. Dr. Tehrani, we had somebody ask, I have pain, but don't want to take a stronger medication unless it's absolutely necessary. How does this person weigh the pros and cons of dealing with some pain versus taking a leap to stronger medications with more serious side effects?
That depends on the underlying diagnosis. If this patient has an inflammatory arthritis, rheumatoid, and they have pain and there's active joint inflammation, synovial lining inflammation, that means the joints can get eroded and cause secondary osteoarthritis, cause more pain and morbidity and so many other things. It's all about cost benefit analysis. And if it's unchecked rheumatoid or psoriatic, my suggestion is to treat it, to target, knock it out. If it's sure, back pain, I have back pain, do I take an NSAID every day? No. Then you can kind of gauge, okay, I have an event, I need to feel my absolute best. And sometimes it's a matter of, again, it depends on what type of medication we're talking about. If it's just general pain, osteoarthritis, you can alternate less toxic meds. I tell my patients, Tylenol arthritis with NSAIDs. Take the NSAID when it's worse, take the Tylenol more often. Tylenol is safer any day over NSAIDs. And of course, topical options like topical NSAIDs, topical anesthetics, there are a lot of other things we can get into. But in general, if you have an inflammatory autoimmune arthritis that is not controlled, it absolutely should get under control. All guidelines recommend you take care of it.
I might just add something too, that this is what's treat to target, because with pain, sometimes people think that with chronic pain, we should be able to take the pain away completely. And that's the goal, but that's not always realistic. So I think another target is function. If you can do what you want to do, if you're a gardener and you can go out in the garden, even though you have a little bit of pain, then you've met your target.
Right.
Yeah.
I'm sorry about that.
No, go ahead. Go ahead.
In terms of pain management, when you've tried your medication strategies and topical analgesic strategies, the other thing is things like electrical stimulation. Things like TENS units have come way down in pricing. I've been a physical therapist now for almost 30 years, and it used to be that you needed a doctor's prescription and TENS units were impossible to get. Now you can buy them for, I just talked to someone about one today, you can buy it for $32. And the size of the pads that you can use them around a joint space, you can use them in a muscle belly, and it gives patients control to be able to at least deal with that immediate pain. And just like Dr. Miller was saying, it's about what's tolerable. So when you talk about pain, it's not off and on, it is how to make your pain the most tolerable. That's the question that you want to ask yourself. Is my pain tolerable? And sometimes your back pain may not be tolerable, but your neck pain is tolerable. Your hand pain might not be tolerable, but your knee pain, it is. So it's varied. It's varied by your activity, but modalities like heat, ice is not a desired strategy, but heat can be a great strategy, and a big advocate for TENS.
Yeah, I would just probably say, make sure you're talking to your doctor or your PT or OT who knows how to use those before you run out and get one, or if you get one, get trained on how to use it properly, right?
Absolutely, absolutely. They're accessible though, more so than they used to be, and that's the kind of item that you do take back to your team and say, hey, I would like to talk about this as a possible help.
Exactly. Thanks for chiming in about, those non-drug type of treatments. We do have a question that just came in a bit ago that I do want to ask, because I know a lot of people with arthritis feel, this is an invisible disease to many. And the idea that you have to go to your doctor and you may look young and you're not older and you have a lot of pain and you feel like the person says, I feel like such a pill seeker asking for pain meds when I'm in extreme pain. What is the best way to have this ongoing conversation in respect to the opioid crisis? And is there anything else that can help? So who would like to tackle that one? Dr. Tehrani or Dr. Harwell?
Sure. So it is. Pain management is very complex. Patients that need above, pain management, we actually refer to pain management specialists, which, is even a separate entity. I try to explain that there are different, again, types of pain. There's that inflammatory, there can be the fibromyalgia, there can be overlap, myofascial pain, intense depression, and, just feeling low mood can make the sensitization that you experience more pain. So I would never feel bad about communicating with your doctor that you have pain, because the source has to be found. You know, if you have ongoing, a lot of times we use biologics and disease modifiers, and that does not suit the patient. The patient has antibodies against that drug. So you should not feel that because you're on one of these biologics or a disease modifier that you should be pain-free. Absolutely not. Patients flare despite these. So we have to understand, we have to know, and that's where the rheumatologic expertise comes in, where we try to distinguish. I use ultrasound as a diagnosis tool. I can detect inflammation in the joints of my patients. And or if the joint is pristine, then I know there's something else happening. There's maybe a mechanical type or something else. So there are ways we are trained to figure out what if the pain is autoimmune, in which case we would treat it. And if not, then again, we refer to pain management. Never feel bad about complaining of pain. It has a source and it needs to be found.
Thank you for that answer.
Yeah.
I don't know. Did anybody else want to chime in with a response to that question?
I think the only thing that I would add is, you know, and I feel so sorry for patients because a lot of times they don't know who to go to even ask for, you know, pain medications. You know, of course, I get a lot of it as a primary care doctor, but the patient may have a rheumatologist, of course, a primary care doctor, and be going to pain clinic.
Mhm.
And when you're in pain, you know, and you pick up that phone, and, you know, I feel bad because, you know, the patients a lot of times don't know who to even call. You know, do I call my primary care doctor? Do I try to call my rheumatologist? Do I call my pain management? And then it's this, well, I didn't write the prescription, so you got to go back to that person. But I would just like to say to everyone out there and patients out there that's suffering, you know, again, it is our job to help you. And it's your job to make sure you seek that help. And I know that sometimes, you know, getting to the end point can be frustrating, but, you know, you should not have to suffer. You shouldn't have to suffer. If you're having a flare, you should not have to suffer, and be persistent, you know, but follow the old grandma's rule of, you know, you get more, what does it say? You get better results with honey than with vinegar, you know, still be nice, you know, when you're, you know, don't, you know, because I know it can be frustrating, but still push, you know, to get the medications that you need.
It's not, I was just going to add that it's not just about pills. It's about different strategies, and pain can come from pressure. Pain can come from structural issues. Pain can come from things that are managed not just with a pill. And so that's why it is a team approach.
Definitely. I would agree about that. And I think understanding the different types of pain, so nerve pain versus muscle pain versus mechanical pain, that's something that takes time to learn. And then as you move through your journey with arthritis, you'll get better at identifying it. I promise. I've had it for 20 years. I know if my RA is under control, but my back pain bothers me more right now. And so there's something different that I would take for that because it's osteoarthritis in my spine. So you will get there. It's just keep learning, keep asking the questions. And I think Dr. Curry, thanks for chiming in, because I think PT and OT are great resources to help you learn and understand those types of pain and pick the tools out of your toolbox that would actually address each type of pain. So thank you. Dr. Miller, I'm going to ask you another question that I know weigh on a lot of people's mind, and that's concerns about common types of arthritis drug interactions that people have. Also, you know, cortisone shots can wear off quickly. You know, is there something else that would have a more long lasting effect? So those are two different questions, but just throwing both at you.
Sure. So with drug interactions, one thing I want to clarify is that if you read that two drugs you're taking interact with each other, it doesn't mean they cannot be used together. Very often it just means adjusting the dose of one or both will take care of things. With your arthritis medicines, there are not a lot of drug interactions that are commonly problematic. There's one I'd like to point out. Sometimes the patients will read that you cannot take non-steroidal anti-inflammatory drugs at the same time as methotrexate. If you see that kind of a warning, it really applies more to high doses of methotrexate that are used for cancer therapy. With low-dose methotrexate for rheumatoid arthritis, the interaction is pretty minimal, and it's perfectly okay to use both drugs together. Non-steroidal anti-inflammatory drugs also can affect blood pressure control. So you might say it's an interaction with blood pressure medicines, but again, we can usually make adjustments to handle that kind of a thing. Then you asked about cortisone shots.
Right.
Well, the cortisone shot would be an injection, say into the knee. There is another injection called hyaluronic acid that can provide longer relief for some people. So that's something to talk to your doctor about as well.
Thank you, Dr. Miller. So we're going to move on to the next topic for discussion, which is prognosis and disease management and outcomes that we want. So the first question is about pain flares. But before we start talking about that, Dr. Harwell, can you please describe what it means to have an arthritis flare?
Basically, it's just worsening of the disease process. You know, you can go for a period of time and you're doing well, and then all of a sudden, you know, you're hurting. So, you know, it's just kind of simply what it sounds like. It's a flare up of something that at some point had already been, you know, sort of simmered down. And, you know, a lot of people, I find that a lot of my patients can sometimes almost predict sometimes when they're going to have a flare. When it comes to osteoarthritis, of course, it's the old, it's going to, you know, it must be getting ready to rain because my knees hurt, you know, and so, you know, the weather change and, you know, those sorts of things. But, you know, just to keep it simple, it's just sort of, you know, worsening of the disease process at that point in time.
Yeah, thank you. I know some people aren't familiar with that and they'll start seeing it and reading about it. So thank you for giving that explanation. Dr. Tehrani, somebody asked that I go weeks without any pain and then suddenly my joint hitches and I'm in pain for several days. Why does this happen and how can I prevent that?
What kind of arthritis do they have?
I'm going to assume it's osteoarthritis. They didn't say specifically.
Okay. Well, osteoarthritis is part of the definition, right? It's where it can be wear and tear, overuse, and various activities can impact the manifestations of symptoms. That's, you know, if you change your activity or go hiking or go on a tennis match, your patients come, you know, after running for a few miles, of course, you know, you can have, so really, I think the activity levels can impact the pain levels for osteoarthritis. I have my gardeners who come, the CMC joint is a key evil. And, you know, everybody who has the carpal metacarpal is thumb pain. And again, this is mostly osteoarthritis. This is our opposable thumb. Gardening season, patients are doing their gardening, they come in with excruciating pain. Well, you know, these activities can exacerbate. So that's probably why an activity modification, splints, bracing, paraffin baths, all of these modalities can potentially help depending on which joint is affected.
Yeah, to clarify, it was osteoarthritis, and so I think
Yeah.
you answered that question.
Modification, diet modification. Again, if it's a gout, for example, patient with, of course, dietary excursions can cause these flares. Multiple lifestyle, in my opinion, reasons why you can get flares.
Yeah, Dr. Harwell, did you want to add anything to that?
You know, I would agree with everything that Dr. Tehrani said. You know, it's just sometimes a lot of what I see is sometimes it's literally just overuse. You know, it's you know, I had the grandkids, you know, this weekend, or you know, I went to a festival, or you know, my church had activities and I was standing longer than usual. So sometimes it could just be our activities of daily living that can just sort of, you know, throw things off. But you know, again, I think that one of the big take-home messages here, once again, is to, you know, I always tell patients, you'll never outrun pain. You know, pain is like a horse. You know, like you're at a horse race, and when that horse gets out the gate first, and then you start trying to play catch up, I think that horse will beat you every single time. So, when you're having these flares, as Dr. Curry also said, there's different, ways and things that you can do. It's not always just about medicine, pills per se, to sort of get ahead of the game.
Dr. Curry, I'm going to throw a new question over your way to switch gears a little bit. A lot of times, especially with osteoarthritis, or even if it's inflammatory arthritis and you already have some joint damage, how can we avoid permanent damage and disability when we have arthritis, no matter what type?
I always want people to understand that arthritis does well, let me put it this way. Your body does not have an expiration, meaning that you are not going to use it to the point of destruction. When you're talking about arthritis, the thing that I think people need to understand is that education, movement, and managing your weight are the three tools that you have to be able to take care of yourself. When it comes to weight management, everybody thinks it's about, oh, I need to lose 50 pounds right away. And it can be something as simple as adding in water when you know that you don't drink water, because staying hydrated helps you to stay active. And some people, they don't want to drink. The common thing I hear in the hospital, because I work in an acute care hospital, the common thing I hear with our older population is, I don't like to drink a lot because I don't like to get up and go to the bathroom. Well, that's not a management strategy. So I would add that, making minor changes in your diet, like adding in a couple of days where you eat more vegetables. There's some great information on the Arthritis Foundation website about diet, but not diet in the sense of deprivation, diet in the sense of balance. And it's about introducing those things that you should be eating, but you don't have to completely substitute out. It's about changing over to more vegetables and adding in more water and adding in more movement, because even those small changes once a week can have a dramatic impact on your life. Exercise progression exercise is not the way that we all learn to play as kids. We have to modify it because now we're adults and we carry more weight, we carry more stiffness. So it's deciding that, okay, today I'm going to turn some music on and I'm going to dance in my house, because that's the kind of movement that you need to introduce. Do something that you enjoy. If you enjoy gardening, think about, instead of getting down in the dirt where it's hard for you to get up, think about, I think I may want to consider a small raised planting bed, because then I can reach it. I don't have to bend over to it, but now I can garden. And that, it's taking the activities that you like to do, taking the things that make that activity challenging, and then trying to bring those two together. That's the way to do it. The other thing with osteoarthritis I'd point out is that when you have osteoarthritis, there are very good management strategies. I work in total joint replacement. I work in a very busy total joint replacement program. And when people hear that they have arthritis, they immediately jump to joint replacement. That's not a strategy for everybody, but it is a very good strategy. And when you start exploring things to help you deal with the pain that you're having with the joint issues that you're having, you can't go by all the bad stories. You can't go by all the 100% great stories. You have to take everything with a grain of salt. So that's where you start looking at programs that do this all the time. You look at programs that have a high volume, that have a team approach, as opposed to just going to one doctor because that doctor's great. That doctor can be absolutely fantastic, but has no support around them. Or you can have a team, there's so many factors. So like I said, I think that when it comes to education and weight management, small changes are great. And then when we talk about movement, we'll talk more about exercise in a little bit here, but I think I've answered that.
Yeah, Dr. Tehrani, some questions about when is it time for a joint replacement? We have several people asking, most of them are knees, they have knee issues, and asking, when do I know it's time for a joint replacement?
Well, it's not a single provider doesn't make that decision. I always defer to the orthopedic surgeon to make the final say. However, early on, there are grading scores that you can look at on imaging, which again don't necessarily correlate with pain. If the cushioning of that cartilage is such that it's worn away, it's bone on bone, and the more conservative non-surgical modalities such as cortisone shots, hyaluronic acid injections, physical therapy, topical NSAIDs, oral meds are, over time, I have patients on those regimens and they say, every 4 or 5 months they come in for a shot, they do great, wonderful. But, some people start to say, oh my gosh, it's lasting only 2 months and now the shot is lasting only 2 weeks. Then, it's time. So, you can tell based on the trajectory of how frequently their symptoms, the arthritis symptoms flare, that essentially would be the time. But you really want to exhaust all non-surgical approaches first because there's so many great ones out there.
Yes. And
Yeah, go ahead.
go right ahead.
Go ahead, Dr. Gray.
I was just gonna add in and to that effect, being educated. Just because you go in and you have x-rays done doesn't mean that you're going in to schedule surgery. So just realize that information is power. It gives you the power to make some good decisions around your care. And when and if you get to the point where you decide to have joint replacement surgery, it has changed so dramatically over the past 10 years. It's not what people think that it used to be. And the outcomes are outstanding. There's people living with joint replacements now. There's actually, I think the last numbers that I saw were that there were about 3 or 4 million people living with joint replacement.
I'll just throw in too that I had a hip replacement about 10 years ago and it was great. I mean, the recovery was not bad at all and I'm totally functional now.
Yeah, and I know sometimes the fear of getting it, and then once you get the surgery, you hear that a lot. People are like, "Why did I wait so long and suffer
That
for
is
so long?"
exactly right.
So I think a question comes down to function. How well are you functioning, and how better could you function if you have this surgery? Dr. Tehrani, before we move on to the next topic, I would like you to please answer this question. A lot of people want to know, how fast does my arthritis progress once I'm diagnosed? Is there a way to slow or delay the progression of the disease, or will it just continue to get worse? And can you answer in OA versus inflammatory arthritis?
Yeah, they're so different. That's why I always try to, distinguish what from what. Inflammatory arthritis. It's all our own bodies that determine this. I can have a patient, so many different scenarios. You can have a patient that has one joint involved that's just recalcitrant, stubborn. I have patients who come in with minimal rheumatoid arthritis disease activity. It's so minimal that they're like, you know what, I don't even want medications. They come back 8 months later, all the joints are swollen, warm, they can barely function. It really, the characterization of, it's not, it's going to go 20 miles an hour and then 45 miles an hour. Unfortunately, our bodies and immune systems do not read these textbooks. It's just based on so many factors that we don't even know. These diseases manifest differently in various people. So it's hard to say. Overall, if you have an inflammatory arthritis, we know that it can progress, causing irreversible damage. How can you prevent it? Of course, with the disease modifying medications. I mean, that's hence the name. They are disease modifiers now. They stop the disease in its tracks. So that's the best way for an inflammatory arthritis. For osteoarthritis, again, unfortunately, no cure. We can't stop anything. But there are lifestyle measures. One being your body mass index. It is key. The other being periarticular strengthening. It's a fancy term for getting your muscles stronger, the muscles and the ligaments and the structures that are supporting your joints. I send everyone with knee arthritis for PT. Why? Because I need the hamstrings and I need the quadriceps muscles strengthened. They are the support for these arthritic joints. The stronger the support, the less pressure you're putting on that poor little cartilage. So that's how we think about it. Get your body mass in check, get everything stronger, and alleviate inflammation from your diet. And that can go a long ways with osteoarthritis.
I think one thing to think about as far as progression for inflammatory arthritis, if you think about rheumatoid arthritis today versus rheumatoid arthritis 30 years ago, you can meet somebody with RA like me and would never know because you don't see joint damage.
Yes.
That was not the case before the advent of all the medications. So that's how you know that it is truly a disease modifying drug. And that's why it's become more and more invisible. Anyways, let's move on to some comorbidities and related conditions people need to look out for or know about when they're recently diagnosed. So Dr. Harwell, I'm going to start with you. What are some of the most common related conditions of arthritis and how can I prevent them?
Well, of course, I think probably the biggest one is obesity, or being overweight, because, when you're overweight, that's more pressure on the joints. And then the extra pressure on, speaking of osteoarthritis, there's more pressure on the joints. And then, of course, that leads to, more pain. And so you sort of get in this vicious cycle. I'm overweight, my knees hurt. And so because my knees hurt, I don't move around a lot. Since I don't move around a lot, I gain weight. When I gain weight, that puts more pressure on the joints. And so you just sort of get in this vicious cycle. So definitely obesity, I think, is a big one. I think one that people really need to pay attention to is depression, right? When you wake up every day and you're hurting, your quality of life is being compromised. That's I think depression is one of the big things that I diagnose a lot in my office with people who have musculoskeletal diseases, because that chronic pain, just puts you in a mood where your quality of life just isn't good. Insomnia or sleep disturbances, right? Because you're hurting. And so I think those are, to me, the big ones: depression, the insomnia, obesity. Now, of course, if you're obese, you're more likely to have possibly hypertension, diabetes. So it's just a cascade, of things. But I like to make sure that people are aware, and I like to make sure that I stay on top of screening my patients for depression and asking them how they are sleeping, because those are things that I think can be overlooked. And those, I think, are two of the biggest comorbidities with musculoskeletal disease that unfortunately may not get addressed in a timely manner.
Yeah, 100% agree with you on that. I know, the Arthritis Foundation has an ongoing insights program study that we've been doing, and 2/3 of the people who have responded, and we've had tens of thousands of people responses, have reported anxiety, depression, and stress. And those, as we've already talked about, can be huge triggers for a flare or worsening of disease symptoms. So I'm glad that you brought that up, because we just recorded a podcast the other day and the guest expert said mental health is health. So it all falls under the same umbrella. Also for other conditions related to inflammatory arthritis versus OA, I think a lot osteoarthritis, a lot of people, I think you mentioned diabetes or heart and lung disease. Is that something that we're at higher risk for, or do you see as a comorbidity often?
I don't know that you're necessarily at a higher risk, but I think that you will see that as a comorbidity. I think probably if you looked at like a Venn diagram where you got these circles that sort of intersect, I think, to me, what I see in my practice is obesity. I mean, I think obesity then causes high blood pressure, and then causes potentially diabetes. That flares up your joints in terms of pain, and then you're depressed and now you're not sleeping. So again, it's that whole intertwining or vicious cycle, as I like to say. But Dr. Curry brought up a very good point when you're talking about diet and exercise or whatever. Movement, movement. I tell patients, yes, it's a vicious cycle, but at the center of that cycle is a solution. And the solution is movement, not exercise, because that's a dirty word. Movement. It's whatever you can do. When Dr. Curry said, hey, if you're going to get up and dance to some songs or, whatever, move. Movement is life. Movement will keep you going. And so that's what I like to stress most with my patients.
Well, that's a great segue into the next topic of physical therapy and physical activity. Just move, Dr. Curry, just move. It's like a broken record. You hear it all the time from every healthcare provider and other people that you know. Well, you need to exercise or you need to keep moving. Can you just help everyone understand the role that physical activity plays in managing arthritis?
Absolutely. So exercise, the term exercise is the scene in Forrest Gump where he talks to him about how many types of shrimp there are. There's boiled shrimp, there's fried shrimp, there's every single type of shrimp.
Oh my God, I love that.
So I want everyone to stop beating themselves up about the fact that they can't run a 5K or they can't, hike to the top of a hill, or they can't. Any type of movement that you do is exercise. Anything that challenges you is exercise. If one of my favorite home health stories is a story of an elderly woman that was living by herself. She had home health therapy and they kept telling her she needed to walk. Well, she lived in a very small, tight space. So what she did is she put two small ashtrays, or dishes, I should say. She put two small dishes at each end of a 25-foot distance. And she took a handful of pennies and she put the pennies in one dish, and she would go and she would take a walk to the other dish and she'd put a penny in the other dish. And then she'd walk back and get a penny and put it in the next dish. And pretty soon that was her way to exercise. It was about the act of getting from one end to a distance to another. Exercise also helps to support the structure of the body. Ligaments are like the rings on a six-pack container, and ligaments hold bone to bone. So just like Dr. Tehrani was talking about, when you strengthen muscle, you are giving your body that extra structural support. It's the belt and suspenders, so to speak. And for people that are really young, people used to wear belts and suspenders to keep their hands up, or their pants up, excuse me. But it's when you start to have degeneration in an inflammatory arthritis, for example, when you start to have degeneration of a joint, it puts stresses in that joint that can actually stretch those ligaments. And when you lose that ligamentous support and you lose the strength of muscle, you can start to see a decrease in the alignment of a structure. Now with the disease modifying medications, that helps to change that process. But ligaments, once they get stretched, they have to have those stresses off of them to keep them strong. So that's where resistive exercise, that's where strengthening programs come in handy. That's where aerobic exercise or cardio exercise is important. There are different types of cardio exercise. That doesn't mean that you have to go out and run a race. It means getting your heart rate up. So one of the easiest things that people can do is monitor your heart rate. Many people have a watch now that does that. There's apps on phones that are absolutely free. If you can go on the internet, you can get this information. The other thing that I would add in, I jotted down a few notes about all this. And so I would add that, introducing exercise, again, it's the small changes in your routine. So when you start to feel bad about not exercising, just get up and walk around your home. You can practice even the act of getting down into the floor and getting up from the floor is exercise for some people because it is difficult to do. And it helps to, when you have things like osteoporosis, you need that weight bearing activity. If you have access to a pool, that's fantastic. And a swimming pool and doing aquatic therapy is great because it unweights the body, the structures. But if you don't have access to that, resistance bands you can add in. You can also bike. Some people have bought 3-wheeled bikes. And so there's so many strategies out there. And that's where talking to someone who looks at your lifestyle and what you have access to and how much money you have. I mean, people can't go out and just buy a bunch of things, but there's so many strategies that are absolutely free.
Yeah, somebody is asking, how do I know when it's okay to push myself through pain to exercise? And can activity ever cause damage?
The pain is actually a guide. I love to use pain as a guide. And as I talk about, is your pain tolerable? That's the first question you always want to ask yourself. Now, there's pain that spikes and comes down, and that is exercise related pain. That's delayed onset muscle soreness, and that may even cause joint related pain. The key thing to understand is, does that pain spike and then decline, as opposed to pain that spikes but may take a longer amount of time to decline? Those are the different types of pain. You never know until you try, but it's sometimes easier to kind of sneak up on pain than to, exceed it. But don't be afraid if you have pain. You are not going to break. Okay. So you have to push yourself to try things. But again, it's not an all or none rule. It is a strategy of trial and error. There's no one right way to do it except not to do it.
Small steps,
Small
baby
steps.
steps just to get moving, right?
Mhm.
Let's move on to the next topic, because we have a few questions we want to get to on this about complementary therapies and supplements. So we'll discuss the role of our alternative therapies and non-drug therapies for pain. Dr. Tehrani talked about some of that in her presentation already, but it's important to understand their role in the context of an arthritis care plan. So we did receive several questions about CBD and medical marijuana and acupuncture. We do have several resources on arthritis.org on our website about those alternative therapies, including 2 in-depth webinars on those, including we have one on supplements, we have one on CBD and medical marijuana. We also have some podcasts related to those. So you'll have to check out those resources because we are limited with time tonight. But Dr. Tehrani, is it possible to use alternative therapies in place of traditional medications? You're on mute, Dr. Tehrani. Sorry.
So for inflammatory arthritis conditions, there is no replacement for disease modifiers. People do that, get joint damage, come back. I don't like to see that. I think you can use it in conjunction with one another. Again, complementary, but not so much as an alternative to mainstay therapies. There are a lot of different things from supplements. I mean, this is a very long conversation, as you know. For osteoarthritis, I do think pain management wise, there are things to take and use that are in a more complementary alternative realm that which may allow you to not use NSAIDs, for example. So depending on the type of arthritis, sure, but if it's really an autoimmune one, I wouldn't replace the main therapies. I think
It's
you're
that three-legged stool that you talked about. That I was just following suit. Oh my goodness, sorry. You have to address it all together. They all work together, right? Dr. Miller, what about what should people with arthritis look for in a supplement, and what kinds of medication interactions should they be aware of? Because there's so many supplements and things out there that say good for arthritis, pain, what should people be looking out for?
Well, with supplements, they're really not regulated very much by FDA. Supplement manufacturers may say they're regulated by FDA, and they are in the sense that they're regulated like food is. So it's a very loose regulation. The FDA doesn't approve supplements. So it's very easy to have poor quality or even contaminated supplements. One thing to watch for quality is whether it has a label on it or a seal for USP, which is US Pharmacopoeia. That is an independent organization that verifies the purity and identity of medications. They do supplements as well. There's another organization called NSF International. So there's some there. There's also an organization called consumerlab.com. They have a database that you have to pay for by subscription, but it's not very much. If you're a real supplement user, I would highly recommend consumerlab.com because they test all the supplements and will tell you which ones are higher quality. You don't necessarily have to pay more money for high quality either, by the way. And the other question was,
What kinds of
interactions.
medication
Yeah,
or
so
interactions? Yeah.
depends so much on the supplement. I would say there are some supplements like fish oil or turmeric that may interact with blood thinners if you're taking something for blood thinning, but they don't really interact with arthritis medicine. So you can pretty much use them together.
Yeah, so always discuss this with your pharmacist and your doctor, especially if you have other conditions that you're being treated for and you have medications, like you were saying, you could be on a different medication. Make sure you are having those discussions with your primary care physician and your rheumatologist, and of course, ask those questions of your pharmacist. Let's hit a topic before we have to wrap up in a little bit on sleep and fatigue, because I know that this is a huge issue that many of you, if you're recently diagnosed, are really now facing, and not able to sleep, feeling a lot of fatigue. So it plagues a lot of people who have arthritis. Someone asked that they feel that even the simplest of tasks are now difficult due to extreme fatigue. Is there anything that I can do? First, I'll answer this by saying, talk about your sleep with your doctor and your healthcare provider. It could be your physical therapist, it could be your occupational therapist, or your rheumatologist, whoever it is. Talk about sleep. Any of us could help you. It could be the way you're sleeping, it could be the environment you're sleeping. If you're having pain with sleep, there are things that you might be able to use to support your joints a little better during sleep. So please bring up that conversation first of all. Second of all, as an occupational therapist, if you have an OT on your team, ask your doctor for a referral with somebody, and look for somebody who knows how to work with people with arthritis. And talk about the fatigue. So there are things you can do to conserve your energy throughout the day. You can pace your level of activities, how you do them, how long you do them, spread things out, especially when it comes to chores and housework, so that you're not doing everything all at once. You don't want to use up all your good days on everything, right? So I don't know, Dr. Curry, is there anything you want to add to that as far as the fatigue goes?
The power of the shower, I think, is a very good thing to remember. A warm bath, a warm shower before you go to bed, if you're having trouble sleeping, is always helpful. You can certainly use things like massagers to help to relax muscles. I know that some people tend to sleep in recliner chairs because it's easier to get in and out of a recliner chair than it is to get in and out of your own bed. But the right type of pillow support, not just your head and neck, but sometimes because your back is aching, sleeping with a small pillow under your side, if you're a side sleeper, or under your stomach, if you're a stomach sleeper, just helps to keep your back aligned. This is the type of thing that an appointment with a physical therapist is not for just exercise, and an appointment with an occupational therapist is not just about exercise. Occupational therapists teach activities of daily living, and they teach home modifications, and there's a lot of tools and tips and tricks that we have working with the body on movement. So sometimes the visit that you have with a therapist is more about, how do I get in the best position? And if somebody has a mattress that doesn't really support them very well, you can supplement that. So it's really about talking through strategies, working through strategies for the best support. And the other thing I would say is, again, the apps that talk about relaxation. Dr. Harwell's point about depression is extremely important, because depression is a hole that is hard to get out of. And you have to acknowledge it to start to heal that. And so by using relaxation techniques, apps that you can listen to on headphones, that noise canceling headphones, even, so that maybe if you sleep with a partner, you don't disturb them, but you can listen to music and just to calm your mind. that's the place to start, because if you're not sleeping, it only takes a few nights of not sleeping to change your mood, to change your attitude, and to take you down that path of just not being able to care for yourself.
Yeah, and potentially increase your pain too.
Absolutely.
So before I move off of this, though, really quick, I do want Dr. Tehrani. Fatigue is quite an issue for people with arthritis, especially inflammatory types of arthritis. And there is an actual condition of chronic fatigue syndrome. So at what point do I know that it's more than just I'm not sleeping well and my body is just tired and just a typical fatigue versus it could be something more concerning?
So things like chronic fatigue, fibromyalgia tend to be diagnoses of exclusion, hence why they are so difficult to diagnose, right? We want to really try to, if somebody comes with fatigue, like you said, rheumatoid arthritis, patients have rheumatoid fatigue. Could it be from the medications that we have the patient on? Methotrexate can make patients feel very fatigued. So once we identify if there's a medication or the active inflammatory condition causing fatigue, well, then that has to be addressed. But if all of those are addressed, things are doing okay. Thyroid is okay. There's no anemia. There's a lot of metabolic, endocrinologic, hormonal causes of fatigue. It's a very all-encompassing and lengthy evaluation. Does the patient have their cancer screenings? Older patient, anemic, fatigue. I mean, is there some sort of a colon cancer that hasn't been detected? All of these things have to be fully evaluated. We should never discount fatigue because it could be a harbinger of something very serious. But if appropriate investigation is done, then it is a diagnosis of exclusion, a chronic fatigue, fibromyalgia. This is a spectrum. There's no unfortunate, definitive test. There are some experimental tests that I'm actually experimenting with myself that would actually be a blood test for fibromyalgia. Regardless, I do a lot of sleep studies, a whole host of lab studies, again, to try to see what the cause is. So I hope that answers kind of the approach to this. So it could be so many things. A sleep study is pretty important to get also.
Yeah, especially if, and if you have a partner who says you're snoring, that is a good sign to maybe
Exactly.
ask, should I do a sleep study? But also I just want to give a plug. We do have a couple of webinars that have already taken place in a couple podcast episodes that go into a little bit more deep detail about sleep and fatigue, and one about finding your balance. So definitely check those out for more in-depth discussion, because the whole webinar is about all of that. Okay. So I want to touch on mental health before we go, because we would be remiss not to answer a couple questions here. We know that getting this diagnosis, if you're recently diagnosed, can bring on a flood of emotions. You're not alone. And I think a lot of our healthcare providers on here today have said that. I will reiterate, you're not alone. You have a community of people behind you to help you get to a support group or get connected with some other people online. Find your tribe of people who know what it's like to be in your shoes. One question that was asked is, since my diagnosis, I can't shake the fear that things are just going to get worse. Any advice on how to take care of my mental health and have a more positive outlook?
And again, I think it's just more of the same of what we've been saying. You're not in this alone. And, you just have to find your own little niche of who can be there for you. It could be, a family member, a spouse. It could be a support group. It could be the Arthritis Foundation. There's local chapters, there's support groups. You're not in this alone. A lot of people, actually, I think the average person has heard of the term arthritis, and knows someone whose joints hurt. So, I think the average person know that they're not, this isn't a disease that's, one in a million. Millions of people, have arthritis. And I think, I just can't imagine if you just sit in the beauty shop and talk to the person sitting next to you, you'll find out that person has arthritis. So it's just a matter of, not being stigmatized by it, and just finding your own little niche of who can be there for you in a supportive way.
Yeah, and I think definitely bringing up in those doctor's appointments how you're feeling. about your new diagnosis with your doctor. They might be able to recommend some resources for you. And definitely the Arthritis Foundation has a lot of resources to get you connected to people in your community. But also we have some virtual connect groups. Silver lining in the pandemic is we're all connected virtually now, right? So there are some virtual connect groups that you could participate in. But I think personally for me, the best thing that ever helped me in my journey with arthritis was being able to get connected to other people like me who really truly did understand how I felt when I walked into the room. I didn't need to explain anything about my pain. They just got it. And so I know there were some comments of people who family or partners just don't understand how you feel. The best you can do is educate yourself and the people around you. And the more that you do and bring loved ones to appointments and get them educated as well, the better the journey will go. It's all about empowering yourself with the information first, so then you can educate others around you. I want to thank you guys so much for being part of this panel. I said it earlier that you're like the dream team of a healthcare team to have. I know somebody said, how do I find this team? And I will again say, ask around, get online, find some support groups and say, hey, who lives in this area? Do you have somebody you recommend? Ask your physicians who they recommend, ask their staff. Their staff probably knows some other healthcare providers that they refer to a lot. There's probably a PT office that they prefer because there's a reason. They probably know that they get good feedback from those people. So make sure you're asking, and please make sure you have a great relationship with your pharmacist. I know that I go to the same one all the time. Recently had an issue where my mail-in supply didn't come in time, and the pharmacist knew me. So he made sure I had a 3-day supply until the mail-in order came. It's all about building relationships with your healthcare providers and getting educated on how you can take control of your arthritis. So I just want to also mention, we do have that app Vim that we talked about earlier. And right now there was a quest that you can join about emotional well-being. So look into that in the app. You can also find more information about your emotional health on our website and our past webinars. We have several podcast episodes dedicated to talking about that. It's called the Live Yes with Arthritis podcast. This conversation has been amazing. It's something I wish I had when I was first diagnosed. Before we do go, I do want to ask each of you real quick, can you give me a roundtable takeaway that you would want to share with our audience to focus more on, the newly diagnosed? So one big takeaway that you want our audience to have. I'm going to start with you, Dr. Tehrani.
Do not be scared. You can navigate it. Find your team. That is the most important thing to get the kind of wheels rolling. But don't be apprehensive. Don't be scared. We're here to help.
Dr. Harwell.
Educate yourself, and then you can educate others.
Awesome. Dr. Miller.
Agree. Educate yourself, ask questions. Don't be afraid to ask questions and get second opinions.
And last but not least, Dr. Curry.
Thanks to all of you. I've learned a lot, and I could talk to this whole group here for hours. I would say the best advice is to contact the American Physical Therapy Association if you're looking for a therapist, and also contact the Arthritis Foundation for resources. Surround yourself with a group of people that can help you to understand, because when you have a tribe of people that understand what you're going through, you come up with solid solutions. So every little bit counts. Don't get frustrated, and just plug away. They say eat the elephant one bite at a time, when you're trying to tackle big issues. So good luck to everybody.
That's right. I like how you said that, one thing at a time. You can't do it all at once. You're going to overwhelm yourself. And then you won't know what's working, right? So one thing at a time, get the disease under some control, decrease some of that inflammation and pain, and take it one step at a time. You have a lot of tools in your toolbox. Just learn how to use them and get the right people to help you to learn how to use them. Thanks again to all of you for joining me this evening on this panel. Before we sign off for the night, I have there's a slide with a few reminders of several resources and events coming up. to help you manage your arthritis. We have several webinars planned. You'll see info on your screen. You can also find them on our website at arthritis.org/webinars. There's one coming up on May 24th about arthritis and how it affects the African American community and some solutions for better access to care. Juvenile arthritis, yes, kids get arthritis too. If you did not know that, there are over 300,000 kids with juvenile arthritis. So we'll have a webinar navigating the middle school years, which is always fun for anyone. I'm doing that myself right now. Gut instincts, everybody wants to know about diet, nutrition, and arthritis. We have a great webinar coming up in June on the microbiome. And then if you want to register again, the website is arthritis.org/webinars. If you also are newly diagnosed, we do have resources specifically for you on our website. The address is right there. I've mentioned the podcast that I host a few times. We actually have a new podcast series, a 4-part series that will be coming out in a couple weeks. That's all about being newly diagnosed with arthritis. You can get connected to some support groups near you on our arthritis.org/live-yes. We do have a helpline to answer any of your questions you might have related to access, insurance, how to find some resources. Please utilize the phone number or you can email them. And then last but not least is our Insights program that I mentioned earlier. We have people who have arthritis or are caregivers of kids with arthritis who can fill out that information to share what their experience with arthritis is like. And that helps us to put together programs like this and provide support to different research programs that we see as a need. Thank you again for being part of the webinar. I hope you found this helpful to you on your journey with arthritis. Please again know that there are a lot of resources out there for you. Let us, keep in touch. And just a reminder, you will receive a survey about your experience during this webinar. So please take time to fill the survey out completely and honestly so we can bring you more topics that are important to you in the future. Thanks again for joining us tonight and have a wonderful evening.